Good morning. My name is Dr. Saha, one of the PACES candidate here today. I have been asked to examine your tummy. So, sir, what I'm going to do, I'll have a good look first and feel your tummy and listen to your tummy.
Okay.
So, do you have any pain or discomfort right at this moment at your tummy right at this moment?
Yeah.
All right. Thank you very much, sir. So, during this procedure, if you feel any kinds of pain or discomfort, just let me know. I'll stop at that moment.
Okay.
Is that all right?
Okay.
Thank you, sir. Thank you very much. So, yes, my dear doctor, this is the Station-01 abdomen. Before starting the Station-01 abdomen, you are rehearsing the important points that you need to look at into the patients, my dear. So yes, my dear, after immediately entering into the room, you need to having a good smile, my dear. As I said, the good greetings. So yes, my dear, the deep bundle packs that you need to follow and you need to do practice many, many times so that you can do the things very spontaneously. So it starts with the Z for greetings, my dear. So yes, my dear, the greetings, introduction, instruction, and the pain, position, and poser. These are the 6 important points that you need to do. So what I said, the G for good greetings, my dear, with the good morning or good afternoon. And with a good smile. This is very much important. And because this smile will win the heart of the patient's mind and making a good rapport. And immediately and during this procedure of the greetings, my dear, the 2 important things that you need to do that wash your hands, and immediately after the wash your hands, then you handshake with your patients, my dear. So like the way that you are saying that, hello sir, my name is Dr. Saha, and you say the good morning, good afternoon, and wash your hands and handshake with your patients and having a good smile. So this is very important. So yes, my dear, the deep bundle packs that you need to do, as I say, the greetings, introduction. Introduction, as I said, my name is Dr. Saha, one of the PACES candidate here today. And then, yes, this is very important, the instructions, my dear. What you are going to do. And during this instruction, you need to see the instruction written here. There is a Station-01 abdomen. Examine this gentleman's abdomen. So you need to tell to your patient, sir, I have been asked to examine your tummy. And during this procedure, what I'm going to do, I'll have a good look first and feel your tummy and listen to your tummy. And then the pain, position, and poser means the pain management, and asking the patient, do you have any pain or discomfort, any parts of your tummy right at this moment? And asking about that, and you say that during this procedure or examinations, if you feel any kinds of pain or discomfort, just let me know. I'll stop at that moment, or I'll be very much careful on that particular areas. Immediately after that, this is very much important, the poser, my dear, means the exposure. The tummy means the abdomen examination needs a mid-chest to mid-thigh for our examination purpose, that we can do the expose the mid-chest, not up to the mid-thigh, like in the inguinal regions, that's enough. But ideally and theoretically, you need to do that. Yes, my dear doctor, the poser immediately after that, the positioning. And for abdomen examination, you need to have the lying flat, comfortable, and always try to tell your patients, keep your patient in a comfortable state. So yes, my dear doctor, you need to expose the patient. So you need to tell, sir, would you mind just put off your gown? Is that all right? So yes, sir. So what you need to do, you just help him unbuttoning his shirt, so you can help him. So it will be helpful to make the environment a positive environment, that you are helping your patients and examiners looking at you. And then doing this one means a lot. And changes and having some of the differences. So yes, sir. Thank you very much. So you put the gown just right at the side of the bed and then lie him on the bed for the lying flat. Yes, the positioning. So this is the exact positioning, and you can ask him, sir, are you comfortable? Excellent. So making a good rapport and saying some of the important words, sir, are you comfortable? Is that all right? And giving some of the thanks because you are moving some of the important points to get the right important findings in your hands. So always making a good rapport and saying some of the body languages along with that, some of the important words will be really helpful to get the science in your hands, my dear. So yes, my dear doctor, that you enter into the room and expose the body for the mid-chest to mid-thigh, if possible, then you can just put on the full gown and whatever the ways that you need to expose the patient. Difficult things is sometimes for the female persons, but don't worry that you need to do that. You need to expose the mid-chest to the mid-thigh, but you don't need to the mid-thigh, just to the up to the inguinal region. That's enough. You need to expose this is the perfect areas that you are exposing. And you consider just putting this down just a little bit down. So that will be fine for him, you see. So this is the exact exposure so that you can examine the patients, my dear. So immediately after the exposure, you can see some of the important signs and features so that you can get an idea that actually the cases approach what will be. According to the lectures that I said, my dear, earlier, that the cases in the abdomen will be the liver, spleen, and the kidneys. So these are the three important organs that you need to focus. So either you need to learn that you need to enter in the room, that you have seen a man here with some of the scar marks in the abdomen, and he has got the right iliac fossa scar, and this is the right iliac fossa scar is nothing but the renal transplant. So immediately you spot the diagnosis so that you can think about that what you need to do further for making all the signs in your hands, my dear. So of course, let's do this. So yes, my dear doctor, immediately you enter in the room, you start with the inspection of this patient, of this gentleman. So what you need to do, you need to start that you thought about this is right iliac fossa scar, so definitely you should think about the yes, this is nothing but a case of the renal transplant, means the end-stage renal disease. So you got the diagnosis in your hands right at the spot by getting the scar marks, so you can think about what things that you need to do in renal abdomen, I said. So yes, my dear doctor, we divided the two cases for the liver cases and the renal cases. So renal abdomen we say. So you highlight about the renal cases so that you need to think about the way that I'm thinking, that you need to train yourself the way that I'm thinking, my dear. So yes, my dear doctor, before starting that you need to rehearse the important points before entering the room that are really effective and helpful for making and for getting all the signs in your hands, my dear. What are the things, if you think about the immediate spot diagnosis, the right iliac fossa scar, so definitely a case of renal abdomen. So you need to think some of the important steps that you need to get the findings in your hands. What is that? The first spot diagnosis, major diagnosis, that is the ESRD, means the end-stage renal disease, that you already got the evidence by the renal transplant. So you need to work on that very, very well. So yes, my dear doctor, let's do the working and then get all the findings and discussions all together. So yes, my dear doctor, let's start with the examinations. An examination starts with the abdomen. Of course, the renal abdomen starts with the hands first. So you need to tell to your patient, sir, could you please just do like this for me? Yes. And you need to put your hands and see like the way that we are looking. What are you looking for? You're looking for clubbing. So he has no clubbing in his hands. So what else that you need to look for? That you need to look for the leukonychia. So yes, he has no leukonychia. Yes, my dear. So yes, my dear doctor, is because you have seen on the hands, the examination starts with the clubbing, my dear, and leukonychia. So sir, could you please just do like this for me? So what are you looking for? I'm looking for the clubbing. So he has no clubbing. I'm looking for the leukonychia. So he has no leukonychia. Sir, can you just turn your hand right, please? And you need to compare with your own hands. And we are looking for the palmar edema and Dupuytren's contracture. You need to feel his hands is soft. No Dupuytren's contracture, no palmar edema. So immediately after the hands that you have seen, that the clubbing, leukonychia, the palmar edema and Dupuytren's contracture, everything is absent, you need to go up, that we are looking for some tattoo marks and the track, means the needle track marks. So we are looking for in the antecubital fossa, no tattoo marks in his hands and also no needle track marks. But, so see, he has got a scar mark in the antecubital fossa. Whenever you found the scar mark, you need to feel here, to feel the bruise. So he has no bruise. So if you found the bruise, so you need to get the stethoscope to put it here, so that you can listen the bruise as well with the bell of the stethoscope. So it's because I have found there is no bruise, but there is a scar, so it does mean there is a non-functioning AV fistula. We have found that in the antecubital fossa, he has got a AV fistula as scar marks, and these scar marks having the AV fistula. But this AV fistula is non-functioning and inactive. These two important points that I said. Why this non-functioning? Because there is no bruit, so that's why this is non-functioning. And there is no question of having the active and inactivity. Active means some of the recent puncture mark, if you found, this is called the active AV fistula, and inactive means no recent puncture mark, this is called the inactive. So the question of active and inactive, whenever the AV fistula is working and functioning. So you can say there is a non-functioning AV fistula as scar marks on the antecubital fossa. There we found. Immediately after that, because you have found on the spot diagnosis the right iliac fossa scar, so you can diagnose it as the right-sided renal transplant is there. And of course there is an AV fistula which is inactive, means the non-functioning, not the inactive, non-functioning AV fistula is there. So this is the previous mode of renal replacement therapy in the form of hemodialysis that he had to take before going for the renal transplant. So you can think in your minds, my dear, the findings that you have found. Immediately after that, you need to go up to look for the anemia jaundice in his eyes. Sir, can you just look up for me? Thank you. Now look down. So yes. So anemia jaundice, he has no anemia, no jaundice. So stick your tongue out for me. So you're looking for anemia once again. Look up, tongue up. You're looking for the jaundice, so he has no jaundice. So sir, show me your gum please. So you're looking for the gum hyperplasia. This is very important, gum hyperplasia, because cyclosporin is responsible for the gum hyperplasia. But he has no gum hyperplasia. And also you need to look for on the chest and neck, especially some of the scar marks is very important. So you're looking for any scars in the neck and chest. So sir, can you just turn your head on the left side? Now right side once again. So yes, we have got a scar marks here. So this is the one scar mark for the chest scar mark for the temporary hemodialysis for the tunnel catheter. So you got a one scar mark in the chest. So he has no anemia. So yes, my dear doctor, you found the right iliac fossa scar and you found another scar in the antecubital fossa and you found another scar then in the chest. So it does mean that the right iliac fossa scar, it does mean the right renal transplant, and another scar on the antecubital fossa, it does mean the previous hemodialysis, and another scar on the chest, it does mean the tunnel catheter for the previous temporary hemodialysis. So it does give a lot of information altogether. So yes, my dear doctor, immediately after that, the findings that you found, you need to work on the abdomen profile. Means that you start with the inspection of the abdomen. So yes, my dear doctor, as because we have done the inspection and we have found a right iliac fossa scar, immediately after that you need to palpate the tummy, palpate the abdomen. So palpation starts and saying the patients that if you feel any kinds of pain or discomfort, just let me know. And you need to sit down the way that I am sitting. You need to kneel down like that. So the level that you need to work. So yes, my dear doctor, you need to put your hands, right hands like this here. And tell him, sir, could you just turn your head on the left side? Turn your head on the left side. Yes. You need to put your hands, a superficial palpation that you can do, just to tell him, is there any pain or discomfort, just let me know. Any pain, sir? No pain. So yes, my dear doctor, that you have found that there is a right iliac fossa scar. So this is very typical for the right iliac fossa scar. It does mean that under this scar there is an organ underlies this scar. So definitely this right-sided renal transplant, the new kidney transplanted here. So you need to work on it fast. So you need to feel and confirm it, and you can feel the kidney just underlying this scar. So this is very important. You need to feel the way that I'm feeling. So you need to feel the organ underlying. So you need to feel the organ underlying this right iliac fossa scar. You need to just put these hands, and you need to see the face of the patient and tell him, is there any pain or discomfort, just let me know, sir. So this is very important, that you can outline the kidney very easily. So I can feel the kidney outline. This is the kidney. So this is the outline of the kidney here. So the kidney structure, so underlying that. So you need to feel this, the kidney. So right iliac fossa scar overlying a mass which is consistent with the kidney structure. And you need to feel, is there any tenderness? So there is no tender. There is a firm inconsistency, non-tender. And of course you need to percuss over this organ. So there you see, this is tympanic. But here, over the kidney, so this is dull. See the dull. So this is dull. So dull on percussion, and of course you need to take the stethoscope in your hands. No bruit overlying the mass. So you need to, just with the bell of the stethoscope, you need to put it here and listen any bruise or presence. So what you found, that you found a right iliac fossa scar overlying a mass which is firm in consistency, non-tender, and dull on percussion, and there is no bruise overlying the mass. Immediately after that, you need to put your hands here. That you feel a kidney, you need to put your hands here just to feel the liver and palpate the liver. So turn your head to the left side and take a deep breath in and out for me. Once again, in and out. Once again, in and out. Once again, in and out. And once again, in and out. 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 So what are you looking for? That we have found that no liver edge is found here. Means the liver is not palpable, not enlarged. Along with that, immediately after that, you need to feel you need to palpate the spleen altogether. It's because you found the liver is not enlarged, so you need to do the upper border of the liver dullness. So you need to do and see the palpate the upper border of the liver dullness. I'm tapping on your chest, sir. So this is the upper border of the liver dullness, and there is no liver. That's the end of the liver palpation. So immediately after the liver that you palpate, you need to feel the spleen from here. So take a deep breath in and out. Once again, 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 in and out. You need to hold it here. In and out, sir. Once again, in and out. Sir, can you turn on the right hand side for me? So you need to hold right here, and you need to put your hands here and just tell him to take a deep breath in now. So take a deep breath in. Once again. Once again. Once again. Once again. So you found the no spleen here. No spleen edge as well. Immediately after the spleen that you palpate, you need to hold your hands right hand here and the back here to feel the nave kidney, means earlier the kidneys he has, so you need to palpate them. So you need to palpate the way they palpate, and you need to ballotable kidney. Just put the hands and put the hands. And also you put the hands here, and you need to feel the kidney, and you need to put like this. So you need to hold the hands here, just medial, just very close to the midline, you see. Because the renal artery, if you can see the abdominal aorta and the renal artery, the 2 centimeters, so the kidneys is here. So kidneys is here. So you need to put your hands and also the ballotable kidney and also palpable kidney. He has no palpable, not ballotable kidneys. So immediately after that, you palpate the renal transplant kidney, and then the liver, then the spleen, then the both kidneys, and then you need to palpate the urinary bladder. So you need to put your hands like this, like this, like this. So just feel the bladder is full or not, that's it. Simple. Immediately after the palpation, then you need to do the percuss to see or to examine any fluid accumulations, means the ascites is present or not. So I need to do the shifting dullness. So there is no dull on the flanks. No dull on the flanks, it does mean there is no fluid accumulation inside his abdomen. So he has no ascites. If you found the dull is there, so you need to turn the patient and wait for at least the 30 seconds and just to see that whether the shifting dullness is present or not. So he has no dullness here, so you don't need to do that. And you don't need to see and examine the fluid trill as well. So he has no ascites. Immediately after the percussion that you have done, then you need to see auscultate his tummy. You can do the auscultate the way that I have done the renal transplant, over the renal transplant, that you've done any bruit overlying the mass, or you can do the all together auscultation. So auscultation needs to see the bowel sound here. And always you feel that you'll get the bowel sound, so you don't need to worry about it. And immediately after that, the renal bruit, just turn the stethoscope and put it here for the renal bruit, put it here for the renal bruit, and also overlying the mass, the bruit. So there is no bruit at all. So you need to see the back to see is there any nephrectomy scar. Is there any nephrectomy scar is present or not? So there are no nephrectomy scar. So you need to see there is any transverse scar like the thyroidectomy scar, but this is not the thyroidectomy scar that you're looking for, parathyroidectomy scar. So he has no parathyroidectomy scar. So he has obvious no leg edema, but even then you just put your hands and just feel that is any leg edema. So he has no leg edema. He has no leg edema. So yes, my dear doctor, immediately after the inspection, palpation, percussion, and auscultation that you finished, yes, my dear doctor, that you finished your examinations, but at the end of the time that you need to see that, sir, just I'd like to see the legs here, just to see, do you have any pain in your legs? No. So he has no leg edema. And immediately after that, we need to tell him, sir, can you just sit forward for me? Just sit forward. Try to be comfortable and just to look, have any scar marks on the back. And you can see over the sacrum, just push it here. So there is no leg edema, there is no sacral edema as well. And he has no scar. So immediately after that you have looked, there are no scars on the back for the nephrectomy scar that you're looking for. And also the sacral edema, he has no sacral edema. You just need to feel within 2, 3, 4, 5 seconds just to feel the cervical lymphadenopathy, or means the lymph glands in the neck regions. So you need to palpate them just to feel them. I'd like to feel the neck glands, just the anterior chain and the posterior chain, and then feel them very easily in the supraclavicular space, and then feel very quickly. So it takes only the 4 or 5 seconds before finishing your full examinations. And tell your patients, sir, thank you very much, and give the clothes and shirts or gowns back to him, and give a good smile, and thank you very much. It will be really helpful. And telling him, sir, you have done really excellent for me. So I'd like to finish my abdominal examination to check the hernial orifices and genitals, and also doing the digital rectal examinations. I'd like to finish the full examination to check the observation chart that includes the pulse, temperature, respiratory rate, blood pressure, oxygen saturation. And I'd like to do the urine dipstick to check the urine for sugar, protein, RBC, nitrates. So saying the 3 important points that you have finished your full examinations. Immediately after that, you need to formulate the full presentations so that you can present your case to the examiner. So what you need to do, you just need to give the back to him, you can help him. So it will make the full environment a positive environment that you're really helping doctor, and as well you're really a caring doctor and saying him, you have done excellent, sir. And yes, sir, thank you very much. And giving a good smile, and you have saying that you are sir, fantastic, you're excellent, you have done a great job for me. So saying these sentences make the full environment, and the environmental effects, the positive effects will have the very good impact on marking on yourself, my dear. So the presentation should be very, very confident look into the two eyes of the both examiners, and you have to come forward with the posture, with the confident posture, and with a very confident look, my dear, is really needed. So yes, my dear doctor, the presentation of this particular case that we are going to discuss, this is very important. So, sir, my clinical diagnosis of this middle-aged man is end-stage renal disease, evidenced by the right-sided renal transplant, evidenced by right iliac fossa scar overlying the mass which is consistent with the kidney, which is firm in consistency, non-tender, dull on percussion, and there are no bruise overlying the mass. And also there is no hepato or liver and spleen, and the kidneys are not palpable and palatable. So yes, my clinical diagnosis of this middle-aged man is end-stage renal disease, evidenced by right-sided renal transplant, which is functioning very well. Because this right-sided renal transplant is functioning very well is evidenced by there is no clinical evidence of edema. And also this gentleman having the previous evidences of renal replacement therapy in the form of hemodialysis, as evidenced by a non-functioning scar mark, a non-functioning AV fistula, because this is evidenced by a scar on the antecapital fossa. And also he had the history of previous form of the renal replacement therapy in the form of tunnel catheter for temporary hemodialysis, evidenced by a scar on the chest. And this gentleman, the right-sided new kidney or the renal kidney is not complicated by the complications of chronic kidney disease, as the evidence by there is absence of clinical evidence of anemia. And I have found there is no clinical evidence of any infections, especially in the skin that I have found there is no clinical evidence of any skin and soft tissue infections. And also I have seen there are no skin lesions. It does mean this gentleman is not having any complications of any immunosuppressions. Because the immunosuppressive drugs having the complications of infections as well as the skin malignancies and some of the skin lesions. And he has no clinical evidence of any immunosuppressions. And I have found there is no clinical evidence of diabetes, as there is an absence of the fingertips pinprick, and also he has any insulin syringes at the bedside. So the underlying etiology of this gentleman, the second diagnosis that I can think, the hypertension, and because of the chronic kidney disease or the most common cause caused by the diabetes mellitus, I have found there is no clinical evidences of diabetes. And the second cause, the second likely diagnosis underlying etiology of this end-stage renal disease may be the hypertension. And for this, I would like to examine his cardiovascular system, to get the apex beat, the healing in nature, so the bedside clinical evidence of hypertension that I can say. And thirdly, there may be the underlying etiology of the glomerular disease. But I have found there is no clinical evidences of any glomerular disease, especially the mesangiocapillary glomerulonephritis type 2, where that we can get some of the facial hypertrophy, lipodystrophy or lipoatrophy. And also he has the kidneys are not palpable, not palatable. So this is also an evidence of the absence of adult dominant polycystic kidney disease, the underlying reason. And also he has no nephrectomy scar as well. So yes, putting all them together, this gentleman, middle-aged man, has got the end-stage renal disease on renal replacement therapy in the form of right-sided renal transplant, which is functioning very well, with the previous form of renal replacement therapy in the form of hemodialysis, and also the temporary hemodialysis evidenced by the non-functioning AV fistula and also the scar mark on the chest. and his right-sided renal transplant or current form of renal replacement therapy is functioning very well, as evidenced by no evidence of fluid overload in the form of leg edema. And also the current form of RRT means the current kidney or the right renal kidney is not complicated by any evidence of chronic kidney disease, means absence of clinical evidence of anemia. He is on immunosuppression, but I have found there is no complications of immunosuppressive drugs as evidenced by the absence of infections as well as any skin lesions or any skin malignancies evidences. And the underlying etiology of this gentleman ESRD may be the hypertension or maybe the glomerular disease, the likely diagnosis. I would like to confirm the diagnosis by doing the ultrasound scan of the abdomen that will give me the idea of the right-sided renal transplant, the kidney size, shape altogether. And also I'd like to see the urea and electrolytes altogether. And these gentlemen, the right-sided renal transplant is functioning very well right at this moment. So my dear doctor, listen very carefully. Whenever you're presenting your case, you must to know and to cover the each and every points of the renal abdomen. The first important point, the diagnosis. The diagnosis, the ESRD, does mean the end-stage renal disease as evidenced by renal replacement therapy. The best and the best and the best course ever you will experience in your whole life, my friend. In the form of maybe the right-sided renal transplant or maybe in the form of hemodialysis. So yes, my dear doctor, the first point is the ESRD, and ESRD evidenced by the renal replacement therapy. You need to look for the current form of renal replacement therapy, whether this is the right-sided renal transplant or maybe the hemodialysis. This is very important, my dear, to look for making your diagnosis. Sometimes the patient may have the right-sided renal transplant as well as the patient may have the hemodialysis, the AV fistula. So yes, my dear doctor, you need to know that which one is the current form of renal replacement therapy. So yes, my dear doctor, if the right-sided renal transplant along with the hemodialysis and having the hemodialysis, the two important talks of the hemodialysis, there is the inactive and also that you say the non-functioning. So yes, my dear, this is the two important words that we need to learn. The AV fistula is functioning means that there is a bruise, palpable bruise and the audible bruise. So if the bruise are present, so this is the active, doesn't mean the active, it is a functioning AV fistula. If you found the AV fistula, my dear, what you need to do, you need to look for the bruise. If you are getting the bruise, the diagnosis is the functioning AV fistula. Immediately after the functioning AV fistula is found, that you need to look for the recent puncture mark. If the recent puncture mark is present, so your diagnosis is the active AV fistula. If the recent puncture is absent, so this is inactive AV fistula right at this moment. It does mean, my dear, this is very much important, and just recap the things once again. You found the AV fistula scar mark, you need to feel the bruise. If you found the bruise and listen to the bruise, the diagnosis is the functioning AV fistula. Whenever you found the functioning AV fistula, that you need to once again to see very carefully whether any recent puncture mark is present or not. Recent puncture mark present, the diagnosis is an active AV fistula. Absent, inactive AV fistula. Active AV fistula means the recent puncture mark means the AV fistula is working right at this moment, means the current form of RRT is hemodialysis by doing this AV fistula. So yes, my dear, having the right-sided renal transplant, having the functioning active AV fistula, it does mean the current mode of RRT in the form of hemodialysis rather than right-sided renal transplant, even though he has the renal transplant. So my dear, this is very important in the exam, that you need to look and you need to detect the current mode of renal replacement therapy. So here's, my dear, the first component, the ESRD, evidenced by the current mode of renal replacement therapy in the form of renal transplant, in the form of hemodialysis, or maybe in the form of peritoneal dialysis, whatever. But the most important, the renal transplant and the hemodialysis. Second important point, the previous mode of renal replacement therapy in the form of hemodialysis, means the AV fistula, in the form of neck and chest scars, that is the tunnel catheter for the temporary hemodialysis, and then the abdomen, the scar marks that you need to look for the peritoneal dialysis. Yes, my dear, if you found the peritoneal scar, means that any scar, any small two scars over the abdominal wall, that you need to think of the peritoneal dialysis that the previous the patient had underwent. So if you found the peritoneal dialysis scar, in that case, that you need to look for other scars as well. What the scars? You need to look for the scars for the complications of the peritoneal dialysis. The scars for the peritoneal dialysis complications, it does mean that the peritoneal dialysis is an entry of the infection in the peritoneum that leads to the peritonitis that may need it sometimes the exploratory laparotomy and the washing the total abdomen. So there may be a midline laparotomy scar, or maybe the right pyramidium, the left pyramidium scar, my dear. Along with the scar, there may be another late complications, maybe the midline abdominal wall hernia, or maybe the inguinal region hernia. So these are the things that whenever you found the peritoneal dialysis scar, then you need to look for the scar for complications, right pyramidal, left pyramidal, midline laparotomy scar for the peritoneal toileting or peritoneal washing for the peritonitis complications. And also this anterior abdominal midline or the anterior abdominal wall, the hernia, as well as the inguinal region hernia. So these are the things that whenever you found the peritoneal dialysis scar. Otherwise, the first point, the ESRD, evidenced by renal transplant or the hemodialysis. Second is the previous form of RRT. Third is very much important that the current mode of RRT, whatever, it may be the renal transplant, maybe the hemodialysis, is functioning very well. Evidenced by the absence of fluid overload in the form of leg edema, sacral edema, facial edema, inner circle. So any fluid overload means that your current mode of RRT is not working properly or is not functioning very well. So my dear, the third important point, that your current mode of RRT is functioning very well, evidenced by absence of leg edema. If you found the leg edema, so you can say the current mode of RRT is functioning less. Yes, my dear doctor. The fourth important point is very important, that the current mode of RRT is complicated by any evidence of chronic kidney disease evidences. Means the chronic kidney disease evidences means the anemia. So absence of anemia does mean the current mode of RRT in the form of renal transplant is functioning very well and is working very well, and no evidence of chronic kidney disease, or not complicated by the current mode of RRT in the form of renal transplant is damaging process. It does mean the current mode of RRT in the form of renal transplant is now structurally, functionally well. Absence of anemia. So this is the fourth important point. So fourth is the complications of CKD, absence of anemia. The fifth important point, my dear, we need to look for, this gentleman is on steroid or not. So the steroid evidences that we need to look for. As for skin thinning, yes, my dear, you need to look for the skin thinning. And also the steroid purpura and the Cushingoid phases, steroid card at the bedside, or maybe the bracelet, medical art, steroid bracelet. So these are the evidences of steroid that we need to look for. And along with the steroid, any other immunosuppressive drugs the patient is on, or this gentleman is on, that you need to look for. What is that? Cyclosporine for the gum herbal tremor, tacrolimus, T for tremor, T for tacrolimus, and also the immunosuppressive drugs complications, the next important points, my dear. So complications of immunosuppressive drugs include that the infections and the malignancies. Infections include the skin and soft tissues infections And the malignancies mean the skin malignancies, especially the squamous cell carcinoma and basal cell carcinoma. Sometimes the skin, some viral infections are there, some of the various shapes and sizes of skin lesions, and sometimes over the skin lesion, maybe the small scars will be there. So you need to see very vigilantly. Sometimes the examiner is asking why this is scar. You need to tell that the skin tissues is taken to exclude the skin malignancy to get the biopsy. So yes, my dear doctor, so these are the important points, and last but not least, that you need to talk about the underlying etiology of the end-stage renal disease. So what are the points, my dear? I'm saying number one, ESRD, evidenced by renal replacement therapy in the form of renal transplant or hemodialysis, whatever. The second important point, the previous form of RRT in the form of hemodialysis, or maybe the neck and chest scar for the tunnel catheter, or maybe the peritoneal dialysis. Third important point, the current mode of RRT is functioning well, absence of leg edema. Fourth important point, the complications of chronic kidney disease, absence of anemia. Fifth important point, this gentleman is on steroid and other immunosuppressive drugs. And sixth important points, the complications of immunosuppressions, skin infections and malignancies. And last but not the least, number 7 important points, my dear, this is very important, there is the underlying etiologies. So my dear, the chronic kidney disease or the end-stage renal disease is the most commonly caused by the diabetes. Second one is the hypertension. Third one is the glomerular disease. Fourth is the ADPKD. That you need to remember, these are the serials that you need to look for any bedside clinical evidences so that you can say that the underlying etiology is the likely diagnosis. For the diabetes, that you need to look for the fingertip spin pricks at the bedside, any insulin syringes, any tablets, any insulin pump, anything else. Along with that, for the diabetic evidences, for the retinopathy that you can see by the ophthalmoscope, but at least that the fingertip spin prick that you need to look for. For the hypertension, that the apex bead, if you are allowed to palpate the apex bead to get the heaving nature of the apical pulse. So here's the diagnosis of the hypertension at the bedside that you can say, other than measuring the blood pressure, because the patient is on treatment maybe. So thirdly, the glomerular disease. Among all the glomerular disease, the MCGN type 2, there is a mesangiocapillary glomerulonephritis type 2, or we call the membranoproliferative glomerulonephritis. So mesangiocapillary glomerulonephritis type 2, we can see the patients having the facial lipodystrophy is another evidences. And also the underlying etiology of the glomerular disease, the membranous glomerulonephritis caused by the systemic lupus erythematosus. In that case, the female, middle-aged female or the young female having the butterfly skin rashes, photosensitivity, discoid lupus, oral ulcer, or with a medic alert breast that is written the SLE on steroid. So the diagnosis done the SLE at the bedside, that you can say the lupus nephritis is the underlying etiologies. And also the underlying etiology, as I said, the next to the glomerular disease, the ADPKD. So you can feel the both the kidneys are palatable and also the palpable kidneys. And also sometimes the ADPKD is having some of the nephrectomy scar. Yes, my dear doctor. So these are the important etiologies that we need to work so that you can say the underlying etiology of the gentleman, the most likely the diabetes because of this, hypertension because of this, and glomerular disease because of this. Or if you found nothing at all, then you can start that, yes, I think the underlying etiology of diabetes may be the reason, and I'd like to see and confirm it, and hypertension may be the second reason, and thirdly, the glomerular disease, and this and that. So yes, my dear, this is the way that you need to present the cases, my dear. And we have found there are the scar marks. You see, the renal abdomen is nothing but the scars that you're looking for. If I'm just describing to the people what the scars, my dear. If it starts from the scars, this is really important, that you start from the scar from the AV fistula here. So scar for the AV fistula, this is very important. If you go up, and then you can scar for the neck and chest, for the tunnel catheters. And if you get down, my dear, there is a right iliac fossa scar for the right side renal transplant. And then if the peritoneal dialysis scar, and also the complication of the PD scar for the midline laparotomy scar, or right or left paramedian scar, or maybe having some of the complications of the hernia as well. and also the scar, the nephrectomy scar on the back, and also the parathyroidectomy scar for the complications of chronic kidney disease, the tertiary hyperparathyroidism is treated by the parathyroidectomy. So yes, my dear doctor, these are the important scars that you need to look for. You need to open your eyes so that you can get the findings of the patients and make your diagnosis. So yes, my dear doctor, keeping all the important points in your mind and boom the presentations in front of the examiners, you will have the tremendous chances to get the high marks in your exams, my dear. I hope that you enjoyed. Thank you. Thank you very much.